Hello, my name is Arkia Pruitt. I'm a PGY1 community-based resident at Wake Forest Baptist Health. Today I will be discussing my research project which is centered on whether pharmacists can impact hospital utilization by participating in transitional home visits. Neither I nor my co-investigators have any conflicts of interest to disclose. I'll begin with the self-assessment question. What interventions can pharmacists make during transitional home visits? At Wake Forest, we have 5 different campuses with 9 different community and specialty pharmacy locations. We also have a Wake Forest house call program that I will discuss in the upcoming slides. In the United States, hospital utilization is and has been a concern for health systems due to increased hospitalizations and ED visits being financially disabling and also linked to compromised patient care. Transitional home visits are performed for select patients at Wake Forest who have a high risk for recurrent hospitalizations or ED visits. Unfortunately, there is little evidence defining whether pharmacists can have an impact on hospital utilization by participating in these visits. Therefore, the purpose of our study is to determine whether pharmacist involvement reduces hospital utilization. At Wake Forest, our house call program includes home-based primary care and transitional home visits. Home-based primary care is a service that offers long-term care to patients and replaces their primary care provider. Transitional home visits, which is what my research project focuses on, does not replace the patient's primary care provider, but rather bridges patients from hospital discharge to their first primary care follow-up visit. The objectives for the study can be seen here. This was a single-center pre-post intervention study, with the intervention being the transitional home visit. The study included all patients who received a transitional home visit during the specified time. A previous study completed at Wake Forest concluded that patients most likely to benefit from seeing a pharmacist in the home were those who were classified as high risk rather than low or medium risk based on their LACE Plus score and electronic frailty or EFI score. I will discuss these scores more in the upcoming slides. I just wanted to point out that in the study, all patients were included regardless of their risk score. The primary outcome that we looked at was the change in cumulative 30-day pre- and post-intervention hospitalizations and ED visits. The 2 separate components of the primary outcome were also evaluated as secondary outcomes. We also looked at the primary care provider follow-up rate and the types of interventions made by pharmacists during the transitional home visits. This timeline outlines how transitional home visits are completed at Wake Forest. Patients are first screened for eligibility using factors including the number of hospitalizations and ED visits. If selected, patients' charts are reviewed by the provider and/or pharmacist. Then, patients are ideally seen in the home for a transitional home visit within 72 hours of being discharged from the hospital. The provider and/or pharmacist makes their recommendations and documents the encounter. During the specified time, 73 patients were seen for a transitional home visit. Pharmacists were involved in 16 of those visits. The pharmacist's role during these visits was to provide medication education and assess any barriers to health care, including medication access and health literacy. Chi-square test was used to determine the changes between the intervention group and the control group, and descriptive statistics were used to describe pharmacist interventions made during the transitional home visits. We can now get into the results of the study. For the patient characteristics between the groups, they were pretty well matched. I wanted to point out the risk scores that I mentioned earlier. The LACE Plus score indicates a patient's risk for readmission. The higher the value, the more likely a patient is to be readmitted into the hospital. As you can see, they were similar between the 2 groups. The EFI score determines how frail a patient is. The higher the value, the more frail a patient is. Although not statistically significant, it does seem like patients who were seen by a pharmacist were more frail, possibly indicating a sicker patient population. The overall risk scores, which takes into account both of these risk scores, were similar between groups. For the primary outcome of the change in total hospitalizations and ED visits, we saw that a lower number a lower percentage of patients who were seen by a pharmacist had a decrease in total hospitalizations and ED visits post transitional home visit. This was not statistically significant. For the secondary outcome of total hospitalizations, we saw that a higher percentage of patients seen by pharmacists had a decrease in total hospitalizations after being seen for a transitional home visit compared to those patients who were seen by a provider only. Similar to the primary outcome, a lower percentage of patients seen by a pharmacist had a decrease in total ED visits compared to those seen by a provider only. This may indicate that the collaborative provider-pharmacist team may have been better at reducing hospitalizations rather than ED visits. We also saw that a higher percentage of patients seen by pharmacists followed up with their primary care provider following the transitional home visit. None of these results were statistically significant. 34 total pharmacist interventions were made in 15 out of 16 of the patients who were seen by pharmacists. Medication education was the most prevalent intervention, followed by medication changes, medication access, and also other interventions, including disease state education. Limitations to our study included the small sample size, especially in the collaborative group. The overall reduced number of transitional home visits due to pharmacist and provider availability was the major contributing factor for the low number of patients. All pharmacists that participated in the transitional home visits were pharmacy residents, therefore lacking experience in transitional home visits. Another limitation is that some patients who were included in the pharmacist group were low or medium risk, indicating that they may not have benefited from seeing a pharmacist in the home at all, based on a previous study done at Wake Forest. In conclusion, I concluded that there was no difference in hospital utilization rates or primary care follow-up rate between the patients seen by a pharmacist versus those seen by a provider only. We did, however, see that pharmacists were able to participate in patient care by making medication recommendations and also providing medication and disease state education to patients in the home. So back to our self-assessment question of what interventions can pharmacists make during transitional home visits. They included all of the interventions listed here that I mentioned that were done in the study. I would like to thank my co-investigators who helped me on this project. Thank you.